So, good day everyone. My name is Faith Alexandra Estrada, and today I'll be presenting a case on the diabetic kidney disease. So, this is a crucial topic in pathology as diabetic nephropathy is a leading cause of end-stage renal disease worldwide. So, let's proceed with the case. The patient has a diagnosed case of diabetes mellitus for the past 10 years with poor compliance to medications. The patients presented with proteinuria, hypertension, and progressive decrease in GFR. The patient later died because of pneumonia. So our case involves a patient with a diagnosed case of diabetes mellitus for the past 10 years. A significant detail here is the poor compliance to medications, which is a key factor in the disease progression. So the patient presented with proteinuria, hypertension, and a progressive decrease in GFR. And sadly, the patient later died from pneumonia, which highlights one of the major complications of this disease. This case provides a framework to discuss the etiology, pathogenesis, and clinical aspects of diabetic nephropathy. The etiology of diabetic kidney disease is multifactorial, but it is primarily driven by chronic exposure to hyperglycemia. From our case, the etiological factors are chronic hyperglycemia. This is the foundational cause. The patient's 10-year history of diabetes and poor medication compliance directly led to persistently high blood glucose levels, which are toxic to the renal microvasculature. Next is hypertension. The patient's hypertension is a critical cofactor. High blood pressure places increased mechanical stress on the delicate glomerular capillaries, accelerating the damage initiated by hyperglycemia. Next is genetic predisposition. While not explicitly mentioned in the case, genetic factors can influence an individual's susceptibility to developing diabetic complications, including nephropathy. Next is lifestyle factors, wherein poorly controlled diet and a lack of physical activity contributed to the persistence of hyperglycemia and hypertension, further worsening the condition. So, the pathogenesis of diabetic kidney disease is a complex interplay of metabolic and hemodynamic changes. So, the following flow chart on the slide summarizes the whole process. So, it begins with hyperglycemia, which leads to several metabolic derangements. First, there's the formation of AGEs, or the advanced glycation end products, wherein excess glucose binds to proteins, forming AGEs that are deposited in the glomerular basement membrane and mesangial matrix, which then triggers inflammation and oxidative stress. Next is hyperglycemia activates PKC, or protein kinase C, in which this promotes the production of profibrotic cytokines. Finally, the polyol pathway is activated, where the enzyme aldose reductase converts excess glucose to sorbitol, leading to cellular osmotic stress and oxidative damage. So, these metabolic changes, combined with hemodynamic changes like hyperfiltration and intraglomerular hypertension, cause a form of mechanical injury to the capillary walls. Over time, these processes leads to progressive structural damage, including thickening of the glomerular basement membrane, mesangial expansion, podocyte injury, and eventually progressive glomerulosclerosis. So, the morphological changes can be observed both microscopically and grossly. So, for the gross morphology, in the early stages, the kidneys may appear normal or slightly enlarged. However, as the disease progresses, they become symmetrically atrophied and shrunken, with a finely granular capsular surface. And the cortex is also thinned, and you can also see the blurring of the corticomedullary junction. So let's proceed with the microscopic morphology. So the microscopic findings are crucial for diagnosis. So what we can find microscopically are the following: Kimmel-Steele-Wilson lesion, mesangial proliferation, hyalinized arterioles, atrophic tubules, and fibrosis. So in the glomeruli, we see a thickening of the glomerular basement membrane. There's also a diffuse glomerulosclerosis, which is a uniform increase in the mesangial matrix. Next is a classic, though not always present lesion, is nodular glomerulosclerosis, also known as the Kimmel-Steele-Wilson lesion. So these are spherical eosinophilic nodules in the periphery of the glomerulus. In the tubules, And interstitium, we see hyaline arteriolosclerosis, which is a characteristic hyaline thickening of both afferents and efferent arterioles. So finally, as the glomeruli bud become sclerotic, the corresponding tubules undergo atrophy, leading to scarring and interstitial fibrosis. Next is the clinical manifestations or clinical complications. So the clinical course of diabetic kidney disease typically follows a clear progression, beginning with key manifestations and leading to serious complications. So first is the clinical manifestations, proteinuria. So the first sign is often microalbuminuria, which gradually progresses to macroalbuminuria and can eventually lead to a full-blown nephrotic syndrome. Next is hypertension. So as seen in our case, elevated blood pressure both accelerates kidney damage and is a consequence of the kidney's impaired ability to regulate fluid and salt balance. Next is progressive decline in GFR. So the most serious manifestation is the gradual decrease in the glomerular filtration rate, and it leads to the accumulation of metabolic waste products, a condition known as uremia. So for the following clinical complications, end-stage renal disease or ESRD. So this is the progressive nature of the disease. It eventually leads to complete kidney failure, requiring dialysis or a transplant. Next is cardiovascular disease. Diabetic nephropathy is a major risk factor for cardiovascular complications, and cardiovascular events are the leading cause of death in this patient population. And next is increased susceptibility to infection. So this is a critical complication as seen in our patient who died from pneumonia. So chronic kidney disease impairs the immune system, making patients more vulnerable. So for metabolic abnormalities, this include fluid overload, hyperkalemia, and metabolic acidosis. So next is, how do we treat and manage this disease? So the goal of treatment and management is to slow the progression of the disease and manage complications. So the cornerstone of treatment includes strict glycemic control and aggressive blood pressure control. So angiotensin converting enzyme or ACE inhibitors and angiotensin 2 receptor blockers are particularly effective here because they are renoprotective, meaning they reduce both systemic and intraglomerular pressure. Management also involves dietary modifications to reduce the workload on the kidneys, anemia management with erythropoiesis stimulating agents, and immunization to prevent serious infections like pneumonia. Management also involves dietary modifications to reduce the workload on the kidneys, anemia management with erythropoiesis stimulating agents, and immunization to prevent serious infections like pneumonia. So when the disease progresses to ESRT, patients will require renal replacement therapy, which can be hemodialysis, peritoneal dialysis, or a kidney transplant. I would like to conclude that diabetic kidney disease is a serious complication of poorly managed diabetes characterized by progressive structural damage to the kidneys. The case we discussed today highlights the importance of early diagnosis, strict glycemic and blood pressure control, and proactive management of complications to improve patient outcomes. Thank you for listening.